What are some things that he did are good, was good role modeling, or things that you think that he did well? Yeah.
I think his whole delivery was very
Mm-hmm.
the tempo, the emotion, showed a lot of stability and not too fast.
Mm-hmm.
And gave information in good doses, enough that I could be able to understand and absorb it at an adequate rate.
Yeah.
So that was probably one thing I could say throughout the whole presentation.
Yeah. And his voice
Yes.
was just amazing,
Yeah.
to listen. So thanks for that. Other things that you...
He repeated his instructions to them and
Go
said
ahead.
that he would even write it down if they didn't understand it.
Yep. Which is, when you have a newborn, I did a lot of PICU. I didn't do a lot of NICU. Complicated. There is an unbelievable amount of information you got to give them right away to be prepared to see it. So, yeah. Yes, right
I
here.
like that he gave the overview. So he said, look, I'm going to talk about 3 things. And we had said the most important was the here and now. And he did that first, right? And he didn't jump straight to the complication. He gave the status update, sort of developed a relationship, developed some trust, some confidence in the system before he related the error.
And he wasn't going to do it that way. So what happened was, when you look, do you see the chair right behind his leg right there? There's a notepad. So they did a huddle, just like you did. They went through all the questions like you did, and he actually shared this notepad with us and how it totally informed him of how he was going to go in and do this. So you can see there's the notepad right there where he took notes during the huddle. And then when you actually look at it, it's what you just said that he had written down. Goal 1, develop rapport and trust. And then goal 2, anchor them to the here and now, how serious it is, but also offer hope. And then get to that point of what they know about the error. And so he found this process of the huddle super, super valuable to help him identify the goals with his table mates, who kind of moved things around and helped him do it. And he practiced a little bit and even said, whoa, that didn't sound right. So then it modified a little. But it was really interesting to see that. Other things you thought that you saw that you liked, that if you were going to use something like this to coach, what do you think was?
I think just to add on to, he kind of outlined the conversation. He mapped it as he went. I'm going to take 3 minutes to explain this, and then I'm going to be silent. And then I'm going to take, 2 minutes to explain this, and then I'm going to be silent. So they knew.
What did you like about that?
The patient, the family knew the silence was purposeful. And it wasn't just awkward, like, what are we doing here and now,
Yeah.
Everybody knew it was a methodical conversation, the purpose of navigating the entire conversation.
Over here.
Because I was sort of bothered by the, I'm going to take 2 minutes. That's an interesting difference of perspective, because when he said, now I'm going to take 2 minutes to explain the complication that happened yesterday or whatever, I'm like, seriously, dude, don't limit it to 2 minutes. I mean, I might need more time. You know what I mean? But I didn't think of it the way you did, so.
Yep. And the value of the actors is that was very comforting to them, because it's like Andy talked about the blizzard. This was the anti-blizzard. In other words, here's the road. It's well lit. Here's where we're going. And he's pausing to allow us to emote. But we know the highway we're on. We're on 35. And like me last night at midnight, coming from Kansas City to Des Moines, I knew right where I was supposed to be going, even though it was dark last night.
I think to add to that, it's our kind of reflex to talk, and that's also him committing to, that's him holding himself accountable to, I have 2 minutes, I'm going to fill it, and then I'm done, and then giving them their opportunity to do what they need to do in this conversation. So.
Yeah, and they love that. When they described it was permission for there to be silence, and both sides agree. And at least for our actors there, again, thank you, Marika and Andy, because they weren't available to do it, but we had these others do it. It was really super. From there, they felt really good about that.
There was an expectation for processing. Built it into the discussion. It's expected that we have to do
Yeah, no, that's great, Tom. Other things that takeaways, sort of lessons learned from watching. Chrissy.
Definitely identified with their emotions, like even some of the adjectives and the way he was describing. I realize you're feeling this way. That's understandable. I thought was really good. He wasn't like afraid to be like, oh, I know this is, I don't remember what he used, not devastating, but whatever the adjective was. I thought that was good that he identified it and he owned up, like it was okay for them to be feeling that way. And I thought it was really good, the analogy he gave too, when he was talking about the heparin and how it works and just the whole thing with the premature babies. Like he really put it on a level that I think someone who doesn't have much medical knowledge at all was easily for them to understand.
So let me ask you this. What did you think of the use of the word Drano?
It personally
Remember, Bruce? He felt weird about it.
Yep.
Yeah.
Said, as soon as I said it, I wish I had not said it.
Yeah.
But then we challenge everybody to say that's pretty descriptive.
Yeah.
Chrissy, what did it?
I mean, I could see
Did you feel weird or?
It would be kind of too graphic or descriptive, but I guess that part didn't affect me because I thought it was just a really good comparison.
Yeah.
Like for them to understand the job of it. So some people might say that was like harsh language, but for me, it didn't affect me that way. It made me be able to clearly understand why this medicine's being used and what its job is.
Yeah. How about others? Was anybody bothered by the use of that? Because it was interesting that it came up. When we asked the audience, though, we could not think of a better word to use that the family at that time would really understand what is the point of the heparin keeping the line open. So, yeah.
When he said it, it kind of struck me, but then after a second I thought, it didn't bother me so much sitting on my end, as if I was, sorry. I said I was surprised when he first said it. It struck me as a surprise, thinking, I'm not sure I would use that term maybe, but then the more I thought about it, I thought, well, that's the best direct way, as Christy said.
Yeah.
It was a good analogy that made it more clear, perhaps.
Yeah, and what I've learned a lot from Bruce is often isn't exactly the words you choose, it's the way, the feeling you get from the conversation. Because that's what I've heard a lot, is that what patients and families take away is the feeling. Did they feel respected? Did they feel like people were being transparent? Did they do that? And again, it didn't bother, our actors who were going through that, but thought it was interesting. Other things that you saw that I think, again, are worthy of, if you were going to use this video to coach people, are kind of nice examples to use. The thing I like a lot is his posture and the nonverbal cue. When he's leaning in, you use that word, Tom, lean in with transparency. He was leaning in and wasn't fidgeting, wasn't moving. He was very, calm, the whole time. How about you, Bruce? Because this is one of the best we've seen in terms of
his tone of
empathy.
voice. He's so calm, as it was pointed out at the very beginning. He's so calm the whole time. I love his structuring of the conversation. He uses very little jargon. He does a very good job explaining things in plain terms. Remember, he did talk to us about he had forgotten the baby's name, and so he kept saying your baby, him, your baby, and he felt terrible about that afterwards. So he said, as a learning point for himself, he would always know the baby's name, to refer to the baby by name. He also, if you could go back and find many, many places where he empathizes, he names their feelings in probably 5 or 6 different places at least, and talks about how terrible and difficult and overwhelming and mind-blowing the circumstances are. So I just think he does so many things well.
Well, and the likely questions, and I know this would come up with us in peds all the time, parents often blame themselves for the predicament that children are in. And so he wrote that in big, bold, prepare for, them, feeling responsible or guilty of the other part about it, because he would see it a lot in the NICU doing that. So he wrote down at least 10 questions that he expected to get, and what the plan was to try to answer them, and working with his table mates to say, what does this sound right? In this circumstance, how does that feel to you doing that? So it was a really good example of showing, again, how valuable I think the huddle can be. Yeah.
I think had he not
not directed the conversation so well, if he would have led with the error, then the whole framing of the conversation would have been different, right? It would have been blame and it would have been anger, but yet he set the stage saying, "Look, preemies have head bleeds, right? This is the norm," and he kept saying 1 hour, 1 hour. The dose was wrong, right? Sort of putting some perspective on it and allowing them to process it, and also not completely blame the system for this 27-weeker with a head bleed.
Right.
I thought that was beautiful.
Yeah, I mean, he expressed.
I agree. I think that what was so beautiful is explaining what happened and how it might have made things worse.
Right.
And that was the moment when, right at the end, he just stops. And then you just see the parents collapse. And he doesn't step in, he doesn't stay, he just lets that happen.
But I would emphasize again also this structuring of the conversation. I think, when we talked about the rhetorical logic of message design, part of that is using language to shape the meaning of the situation, to shape the goals, the roles. And he does this explicit, we call them explicit contextualizing phrases. He's building up the context for the whole discussion and telling you how it's going to go. And I think in a really frightening, uncertain situation, it's comforting to the family to have this structure. It's also, one way to think about the goal is, I want to manage the family's emotional response to the situation, not in a controlling way, but in a helpful, empathic way. And one way you manage their response is by giving them all these preliminaries about what's about to happen and constantly orienting them. It's a disorienting situation. To have a premature baby, to be in a NICU, to have an error, it's all so disorienting. And he's constantly orienting them. And I just thought it was so powerful the way he did it. And he did it all instinctively. We didn't teach him to do that. That was his own instinct. And I recommend that as a skill. And Tim and I, when we see so many hundreds of these assessment messages in the disclosure situation, in the assessment messages, we find that the best message producers often use explicit contextualizing phrases, especially to prepare the family for bad news.
Yep. And so how it'll often read, and again, we do, Bruce, we have 1,200 now. So no, what you will see, those really rhetorical in the last part of the assessment piece is, they will begin with introducing themselves, saying, let's find a quiet place, and then say something that we call the shot across the bow, which, this may be very difficult news that I'm about to share, with you, or you may find what I'm now going to share with you very difficult to listen to. Again, we call it the shot across the bow, because you want to talk about, because that's what he does in a very kind and subtle way that takes him into that rhetorical range, like he did in his assessment, that I think is worth talking about, Bruce, because we always try to look for that.
You're doing them a favor and a kindness by preparing them for what they're going to have. It allows them to gird themselves just a little bit and set their expectations for what's about to come. Now, if you're really delivering very shocking bad news, nothing can take away the intrinsic shock of having to tell someone that their loved one has died or that they have a really grave diagnosis. But you're still at least not giving it to them completely out of the blue. So you're not compounding the gravity of the news with abruptness and suddenness and being like as if you're being taken completely by surprise. So you're doing them this courtesy of preparing them that I have something very difficult to tell you, or I'm sure you weren't expecting to hear the news that I have to give to you now. We hear all these contextualizing phrases, and he doesn't do exactly that in prepping for the bad news. He does it on an even wider scale. He sort of prepares them for the entire conversation and lays out this roadmap. And I think the effect is a really positive one in general. And also, these actors didn't quite do it, but you can imagine people disagreeing with the roadmap of the conversation or saying, I want to do things slightly differently, or can we talk about this first, or whatever. And there would have been room for that.
Yeah, and what we talk about is, when you do the huddle up and you do the plan, people often think about it as being in a canoe and rowing down a stream. In some of these difficult ones, it's not that at all. You're on a kayak, you're on the rapids. No, and you got to go where the family takes you. You go in with a plan, but often you have to throw that plan out based on what Bruce just said, and you just got to go with the flow. And no, you still have these goals. He still has those goals, of trying to maintain trust, anchoring them, but they may decide they want to go someplace different. And you just got to keep going, but ultimately trying to hit what your goals
Think
are.
of how sophisticated his goals are. This goal of anchor the family to the seriousness of the condition, but provide hope. I hadn't thought of that goal exactly. That's a really deep and experienced person who thinks about that goal. So I might have a goal like comfort the family or something like that. And some people, even less experienced, might think make them feel better or whatever, ease their anxiety. But he really knows actually telling them this is a very serious situation is a critical goal to achieve. And he makes that really the first thing that he does. Mm-hmm. This idea of anchoring. And all of it, I think, is he is in control. He's using his rhetorical powers to create the meaning of the whole situation and manage their perceptions and reactions. It's a very sophisticated use of language. Mm-hmm. And we sort of asked this guy, how did you figure all this out? How did you learn to do this? And his father was a pastor. That's what he gave the credit.
That was a tear-jerking piece when he described his own life and the horrible things he went through. Oh my God, he's lived it for sure. So anyway, we wanted to share that with you because that's the value of doing a lot of these trainings. And people often say, can you show us a really, really, really good one? Yeah. And finally, we had one.
There, you've seen a really, really good one.
There it is. Good
night, everybody. No, we have to continue.
All right, so we're going to shift gears, Bruce.
Yes.
And let you chat for a while,
Sure.
and then you'll hand it over to me when Truth is Stranger Than Fiction.
Thank you very much.
You bet.
Okay, so your hospital has committed to doing something like Candor. You're going to start telling the truth to patients and families when bad things happen. You're going to set up a system in your hospital for rapidly doing event review and working towards resolution, waiving bills and charges. You're going to build all this infrastructure. One of the things that you're going to have to do, one of the first decisions you're going to have to make when you commit to this is at what severity are we going to trigger this whole process? Because at UIC, it was a whole process, right? We'd call the patient consultation service. We'd make sure someone talked to the family. We would hold the bills. We'd maybe notify the media relations people. That we'd trigger this whole process. So the question is, at what point do you trigger this process? So you have to draw a line in the sand in terms of severity, and we can't tell you where to draw that line. Each of your hospitals or your systems will have to do that. So we have examples at UIC. Tim and his colleagues and Nikki decided any harm, physical or psychological, was enough to trigger the system. So it was a very low threshold of severity. We have another hospital at Christiana Care in Wilmington, Delaware. When they adopted this, they were very nervous that they were going to be overwhelmed by Candor cases. So they set the threshold of severity fatal harm, because they were very worried that if there was any less than that, they'd be overwhelmed and wouldn't know how to handle it. They've since backed down to, I think, permanent harm or serious harm as their threshold. So you're going to have to set this threshold. So we want to talk some about these thresholds. And you're going to have infrastructure, systems, processes in place to make decisions about individual cases, about how you're going to respond. So there's a whole bunch of other conditions and circumstances which we can anticipate, having been through a lot of this. At what point, is there ever a circumstance where you're going to withhold some documentation or some information? Will you always be 100%, literally 100% candid and show them everything? And I think the answer is not always completely. The example Tim often gives is that there may be a root cause analysis, an internal investigation, where the surgeon and the anesthesiologist hate one another. They've been feuding for years, and they were arguing in this case. And in the root cause investigation, they were hurling obscenities at one another. Does the family need to know that? Are we going to tell them all that? That's not necessarily information the family needs to know, or every single bit of how the sausage is made. They deserve to know the conclusions of the investigation. There may be a variety of ethical problems, and we're going to show you a real-world case that raised a variety of serious ethical problems in a minute. What happens when it's somebody else's error? When into your ED rolls a patient and you discover there was a sponge left behind in their abdomen and they're septic, but it didn't happen at your hospital, it happened someplace else. What are you going to do about that? All sorts of system issues, team problems that can go along with. What about residents? What are you going to do when residents are involved in errors or when residents observe bad behavior on behalf of their seniors? And then, these things happen all over the place. And as Tim likes to say, they happen late Friday night at a remote facility. They don't happen Monday morning at the main hospital when everyone's around. It happens when the CMO is on vacation, the CNO is sick, and that's when all these bad things happen. You have to be prepared for all that. But I want to talk about one particular set of circumstances when we have to try to decide whether an error has been made and whether harm has occurred, because these are going to be critical questions you have to ask yourself before you talk to the patient and the family. Has an error occurred? Has harm occurred? So I want to give you some kind of academic definitions, and we'll talk through some of these cases. So the big red circle is the whole universe of medical errors, all the things that we do wrong. Wrong drug errors, wrong patient errors, procedural errors, surgical fires, falls, all the different terrible things that can go wrong. Inside the big red circle is the little circle, potential adverse events. So this is all the things that where we made mistakes and the patient sure could have been hurt, but they weren't. Because we had enough double checking, triple checking, safeguards, guardrails that sure enough, somebody ordered a tenfold overdose of heparin, but the pharmacy caught it. Or somebody ordered it and the pharmacy filled it, but a nurse caught it. So those are all potential. They're errors for sure. That tenfold overdose was surely an error, but it didn't get administered to the patient. The patient wasn't harmed. So those are near misses. They're critically important for learning. In fact, they're orders of magnitude more common than actual events that harm patients. The things go wrong all the time. Just reflect on your own experience. Things go wrong all the time, every single day. But because of all the safeguards we put in place, most of those things that go wrong don't hurt patients. But we need to learn from them. And sometimes things get to the patient, but the patient is resilient. The drug wasn't that toxic. And even though we administered it to them, it didn't hurt them. So we're just lucky. And the object is to learn from that mistake. In the blue circle on the right are all the adverse events. So what are adverse events? What's an adverse event? You got a good definition? Not an expected outcome. That's one definition. What else? What's the sort of critical defining feature? What does the word adverse mean? It causes harm. That's right. So the government, the AHRQ, CMS, others, they define an adverse event as harm caused by healthcare. Very simple definition. Harm caused by healthcare. So the blue circle is all of the things that the ways that patients are harmed by healthcare. But notice that the blue circle and the red circle don't completely overlap. So the non-overlapping part of the blue circle is all the harm that occurs when there was no mistake. So the fact is, very sick people with multiple chronic diseases, undergoing very risky procedures, who are frail and have multiple organ system weaknesses, bad things occasionally happen to them, right? So we have a patient, they have heart failure, they need an operation. They're not a very good surgical risk, but they insist on having the operation. Bad things can happen to that patient. We have patients with kidney disease, but they also have cancer. Now we have to give them chemotherapy. We're pretty sure the chemotherapy is going to do a number on their already very weak kidneys or their already diseased liver. What are we going to do? Sometimes people get hurt by healthcare and there's no error. In fact, think of chemotherapy. Almost every single patient who undergoes chemotherapy is harmed by chemotherapy. And there's no mistake. They vomit, their hair falls out, they have open sores, they have extreme fatigue. It's harm caused by healthcare, but it's not an error. And then we have the overlapping part. So that's the preventable adverse events. That's when we've made a mistake and it harms a patient. So that's like the area that most of us focus on because we think that's where we can prevent people from being harmed. We can stop making these mistakes and therefore prevent people from being harmed. So let's give a couple of cases. And here I just want you to think, is it an adverse event? Is there harm caused by healthcare? And was there an error? So let's take the first one. Patient undergoing routine abdominal surgery has their ureter nicked and repaired. Is that an adverse event? Yes. Raise your hand if you think that's an adverse event. Is there anyone who wants to claim it's not an adverse event? Okay, so there's yes and uncertain, or don't want to raise my hand. So why is it an adverse event? There's harm. What's the harm? Yeah, their ureter was intact before the surgery, and then it was nicked. Even if it's completely repaired, there's no leak or anything, that was harm caused by healthcare. Was it an error? Who said that? Maybe. Right. I think that's about the best answer we can give with this one sentence description. You want to elaborate on that at all?
Well, maybe there was a cancer eroding into the...
Oh, yeah. Yeah.
If there was a cancer eroding into the ureter,
Yeah.
then of course we had to cut it out. So it wasn't an error. It wasn't preventable.
That's right.
If the surgeon didn't properly identify the ureter before they took a pedicure,
Yeah.
then it was an error.
Right. So we can imagine it being an error. We can imagine it not being an error. The patient had unusual anatomy. The patient had very bad adhesions. They were morbidly obese. Who knows what the circumstances were? We don't know. But these are the kinds of decisions you'll have to make about every single case. And you'll have to reach some sort of agreement or consensus before deciding how you're going to go forward, because deciding whether to admit your care was inappropriate or not is one of the critical decisions in Candor. The second one, patient with history of penicillin allergy gets a prescription for Augmentin, which is amoxicillin and clavulanate. He completes the course without problems. Is this an adverse event? Raise your hand if it's an adverse event. Why is it not an adverse event? There's no harm. He completes the course without problems. By definition, an adverse event is harm caused by care. There's no harm. Is it an error? Who thinks it's an error? Raise your hand if you think it's an error. I'm not totally certain about this one. Is anybody, do we have a pharmacist in the room? We didn't bring in pharmacy today. Okay, so can you see a scenario where it's not an error?
It's a systems error.
It's a systems error, but that's still a kind of error. Exactly. If you look at both the documentation of allergies and the accuracy of these so-called allergies, it's highly suspect. So it sort of depends on, but if you said it's an error, why? Because you've given them a contraindicated medication. If we sort of take things at face value, we assume the allergy was documented. That's right. What if it was anaphylaxis that they had before? Then it's a really serious error. The next one, patient receives 20 milligrams of Lasix twice daily for 2 days rather than once daily as prescribed. They experience increased urination but no other problems. Is this an adverse event? I see one nodding head. Somebody said no. Who said no? Why no?
It doesn't seem like there's any harm.
But Bruce, I'm a truck driver.
Exactly.
And
Tim
man,
is a trucker.
I got to tell you, when I got to pee a lot more, it is a huge inconvenience and even a financial problem for me.
Yeah, so I think this is where we have to be more open-minded about what harm is. We have to think about and here UIC had a very open-minded policy. Their policy was if there's even psychological harm. So if they perceived that they were harmed, you would put Candor into motion. So were they harmed? I think we could agree the harm was not serious. The harm was not profound, was not permanent. But was there some harm? I could probably be convinced that there was, if they lost sleep or their employment was interfered with. Was there an error? Yeah, this is just a flat-out dosing error. They got the wrong schedule. Tim.
So, what he's trying to get at is, when are those situations going to be when you're going to go in, you're going to tell the family, here's what happened. What is the value, and I want to go back to what Tom said, in going in and telling that patient, you may have had to get up a couple more times during the night to go to the bathroom. I want to let you know you got twice as much Lasix as you could have. We're sorry about that. What's the value in doing that? For the organization, getting back to kind of where Tom was coming from.
It's the practice
One, you get to practice doing it, but it's also do you remember what was in red on the title slide? The goal of Candor? It's to normalize compassionate honesty. It's part of normalizing honesty. A mistake was made. It could be viewed as harm. It just becomes your norm that you do that. And that's why we're kind of pushing this a little bit. This value of transparency forces you to hold yourself accountable. Because what's the other piece about this that's so powerful? How'd that happen? Is there a really big system issue there that if we fix this, we may save a life?
I thought you were driving at something slightly different. What if this guy thought that he was going to pee this much all the time? And he said, the heck
Stop
with this
taking
Lasix.
all his Lasix.
I'm not going to take any Lasix. This is terrible. So you could explain to him, oh, no. You're still going to pee a little bit more than you would ordinarily, but it's not going to be that bad. So let's take another one. Patient recently diagnosed with breast cancer in the surgeon's office. She sees her mammogram from the prior year and notices a spot in the same area where her cancer was diagnosed. So is this an adverse event? Does anybody think it's an adverse event? I see people thinking hard. What does it
Oh, here
depend
you go.
on?
There you go.
It would totally, maybe that spot was identified before, but a radiologist and the surgeon said that it wasn't significant. Maybe without a medical diagnosis of that spot, just a layperson can't really make it.
So you're thinking about harm in terms of, was her diagnosis delayed?
Yeah.
Did anybody else have any other thought about harm? I was just thinking like the
would there be
freak-
psychological?
That's what I'm thinking about, the freak out
I mean, I
value
gotta
of
just-
the harm. Yeah.
I have to just toss that out. What's that?
Exactly.
Yeah, I mean, yeah.
Some sort of anxiety, suffering, second guessing, et cetera. And I agree in general that to really answer this is going to require more in-depth investigation. But so if this isn't that implausible of a scenario, right? You can imagine the scenario happening in your hospital, I presume. So what are you going to do in a scenario like this? What are you going to explain?
You get the mic back.
Hopefully the surgeon has knowledge of what the spot was in the past mammogram, and the surgeon should explain, okay, this is just what do they call it, a distortion. It doesn't signify cancer without a biopsy.
It's in
We
exactly
wouldn't
the
have
same
known.
spot as my cancer ended up being. I'm pretty suspicious. Why didn't you diagnose me back then? I'm listening. Yeah, see, the patient's going to be
I'm not a
very
surgeon.
tough. Yeah. Yeah, so maybe Tim can talk about how this might be handled.
So actually, we were talking about this earlier. This is a classic case where you'd want to take this mammogram and put it in with a whole bunch of other ones to see whether or not this thing is something that would raise suspicion with a whole lot of people. And if it wouldn't, then it's not a mistake. It's possibly an artifact. It's something that's there.
Yeah.
But you're going to have to address this issue. And there's a lot of different ways to do it. One is to show up the different mammograms, to show up how it changed, whatever it is. Just being transparent, and explaining to them, here's what it is, here's what we see, here's what we know is the
And
the response,
empathizing with
is the
their
response.
concern and their anxiety and their
Yep.
fear that it might have been caught earlier, all that stuff. And even then trying to explain to them and help them understand the power of a retrospective bias. You say, yeah, man, boy, now that we know where your cancer grew, we can look back at this, and it sure seems like we can see the future, but we didn't know then what we know now. And if we had just seen this then, there was no way for us to know.
Mm-hmm.
And it's a hard point to get across. But I think, yeah, Tom.
Something to put into your brains as you think about this is that, we're assuming guilt with
Right.
regard to
That's right.
this testing. And remember, these tests are not perfect. There are false positives and there's
Yep.
false negatives. So there's a gray area with how all of these are interpreted. How many people have had a mastectomy because of a false positive? So
many.
The whole point is we go slowly as we do the diagnoses. So I guess I just want to interject in here. Remember that our tests are not perfect. And we have to work that into our argument.
Yeah, so we understand that to a certain
Yep.
extent. The question is helping patients and families understand that,
Yep.
and also
Yep.
helping them in retrospect when they've already lived through cancer and chemotherapy. How can we help them understand that then? I think the answer to many of these questions is in the consent process, in our long relationships with patients, to educate them about every test we do, to talk to them about sensitivity and specificity or false positives and the imperfection of our diagnostic process, so that when this happens, we have something to build on. So here's a more complicated case. A 19-year-old comes to the ED with signs of meningitis and septic shock, is intubated, gets a central line, and is resuscitated with fluid and pressors. Once they're stable, they go to get a head CT. The CT is completed, but moments after moving the patient back to the stretcher, he becomes hypotensive. Resuscitation is attempted, but he never responds, and the code is called. As the team's preparing to take him back to the ED, they realize his central line had become disconnected in the bed sheets, and none of his infusions or resuscitation meds had actually been administered. His CT scan showed massive cerebral edema and impending lethal tentorial herniation.
Yeah, which is to say, he's not going to survive.
Yeah.
Based on no matter what happened, no matter what medications were given, he was going to die from
He had a
from
fatal
this issue.
condition basically when he came to the ED.
Right.
So is this an adverse event? We have one yes, a tentative yes being withdrawn.
It's a yes?
I was thinking air. In my head, I heard.
Okay, so let's ask first, is it an adverse event? Is there harm caused by healthcare?
I would say it's near miss.
Someone says it's a near miss.
What's that?
You didn't help.
The absence of help harm.
I think that's the crux of it. I think that's the crux of it, actually.
Yep.
She said, we didn't help. Is the absence of help harm? That I think gets to the error part.
That may be the error.
That gets to the error.
That
Like
may be the error.
procedurally, we didn't deliver those meds.
And real specifically, from the patient's family's perspective, what would the harm be?
Think about their family.
Oh,
in the
you
ED.
can. Think broad about this. There's the wondering.
That's what they're gonna think. They're gonna think, what do they mean?
Well, that's on the error part.
What else will they be thinking?
He would have died no matter what. We know that for
think you
sure.
could-
But
you'd
you're
be
going. Take that a little bit further. Take that piece a little bit further. Bingo.
Yes.
You're our non-clinician, right?
Yeah.
No. So it's a lot of the
Sometimes
times it's
it
the
takes a
non-clinician.
non-clinician to see.
So say what
Yeah.
you're thinking here.
Well, if it didn't get caught, if I'm understanding it correctly, then would he have lived longer? Would we have had more time to say goodbye once they
Yeah,
realized
Yeah.
Perfect.
that?
Yep, yep,
Perfect.
yep.
Well, and which came up at another one. Who mentioned organ?
She right here.
That's the
yeah.
other piece. So one is it's this time say goodbye. So because the given is he is brain dead. It's herniated. He's brain dead. But then you have the organ transplant, which we came up a couple times ago. But I'm glad to hear you say it. But it's the time to say goodbye. And there are people who would say, many people actually, when you talk about like that, that's harm. So you can now take it.
Yeah.
Take it a little further.
Was there an error? What's the error? Yeah, I mean, those lines are supposed to go in the body. They're not supposed to drain out into the sheets. So regardless of the consequences. So this is one of the hardest parts about thinking about error is we have to divorce it from the consequences. Sometimes when really bad things happen, we're more inclined to think there was an error because there was a bad outcome. Or when nothing happened, we might be inclined to forgive ourselves because there weren't any. But whether or not there is an error, that has to do with, was the action as intended? And the action was not as intended. The intention was to place the central line and to infuse those meds into their body and so on. When it comes undone and they're not, that's an error. That's a procedural error. Whether it has consequences would have made any difference is a separate question. Okay, I think now I'm going to hand it back to Tim. Oh, no, we have a couple more. Do you want to skip these, Tim, and move on to yours?
Well, sure.
This is more of the same.
Given how
I think.
disturbing mine is.
Yes.
Yeah.
So Tim has a real case which sort of brings all this together, including all the ethical issues, and I'll hand it over to Tim for that discussion.
And it is, you will be, I'm just warning, this is a shot across the bow. I'm going to share a case with you that is very disturbing because it is so true. And I think it really brings together a lot of the spectrum cases, Bruce, as you set it up. So this is a patient who a couple of years ago had been in the operating room, had this craniectomy done, had a bone flap was put back on, comes back 2 years later, has some things that are has a history of anger management, some other sorts of things, but comes back for part of a neuro evaluation and ends up getting another skull x-ray. The radiologist looking at the x-ray from today, compares it to 2 years ago, sees this x-ray and goes, you gotta be kidding me. So really look carefully at that x-ray. Does anybody see a word or words in that x-ray? This room is so great. You guys are all sitting very closely. And what the radiologist said, and I'll point it out to you, is an S, a U, and an X that had been drilled into the skull.
Yep. And
above it is a name. This is from 2 years ago. The current x-ray you can't see it because it's all scarred in and healed over and all that. But this is what the x-ray from 2 years ago shows. Okay. So, is there harm? Is there harm?
Yes.
What's the harm?
They have tampered with his body. They disfigured his body.
So they disfigured his body. He doesn't know about it.
Right.
So, and by the way, when you check with the neurosurgeons, there's exactly the right number of holes that have been drilled. Because that's what they do to help it heal, to reattach and do all that. So it is absolutely the right thing to do. The bone flap healed well. There's no harm to the bone flap. There's nothing like that. There's just this, is what you see.
So they did what they were supposed to do, but they did it in a very creative way.
Well, they did it in a super creative way. That's why I did the shot across the bow, and I am so sorry about this. I mean, no, but it caused. So I was consulted on this case. This is one of the 200 organizations we're working with in the country where we get really complicated stuff, and they'll say, "What would you do?" And so we try to go through this process because it's just super helpful to really begin to. You're going to see when you really become transparent, you're going to hear more and more about the crazy stuff that goes on, particularly if you work as the consultants, the Candor people in your organization. So the question
Tim,
is,
I thought there was another hand up right here.
over here.
Oh, yeah, I was going to say, is the name that is on here the name of the patient?
No. So good question. So the name is the name of the supervising resident of the resident who drilled the holes, who has bullied him for at least 2 years when you do the peel back to kind of understand what happened. And then I'll share a little bit more with that. When this originally occurred, a radiologist saw it, called it to the neurosurgery team. They reported it to the program director, who said to the resident, "Don't do this again." And that was it. So we're going to get into just culture in a little bit. That's the conversation you see on the agenda. We have there later doing that. But the question is there harm? Well, there is that piece, and that is, she said, psychological harm to the residents. So there's a lot we need to think about systems issues and how this happened the rest of it. The question is, because remember, if there's harm, and clearly this was intended to be sort of malevolent, so when you get into just culture, this is that piece of it. But the question is, would you, it's 2 years later, it's not on the x-ray now, do you pull your Candor team together and tell the patient, here's your x-ray from 2 years ago, and here's what it says, and we're really sorry that this happened?
What would you hope to achieve by doing that?
You tell me. I love it when Bruce taught me this, when people ask me questions. I can ask you the question right back. So Dar, let's talk about it. What don't we just talk about in the case of the Lasix? What is the value in explaining this to the patient?
It appears as though in this instance there would be no value.
Well, the value to the organization is you are being transparent.
To the organization, yes.
To the organization. The question is so the question is well, let's talk about that. Do you think there's value in being told that during surgery somebody burned their initials into an organ?
Would we be causing more psychological harm telling?
So that's the question that came up at the what she mentioned, Bruce, which does come up is, and we always got to be careful of it, is would telling the patient be the harm that gets caused by this piece of it? Would we be causing more harm?
I think you have
And
to let them be the judge.
well, and there you go. And a lot of people said, well, you got to let the patient be the judge of that because this goes back to the priest concept. It's very paternalistic to say what we say is, oh, you're going to be hurt more by this, versus there's value in you learning about this. What is one of the risks if you don't tell the patient at this time you know it? What's one of the risks? It'll be found later, and he'll be told, and now you're going to have somebody who's really pouty. No, really. Right, no, and he does. This is a true case. This is why it was, what you say is very relevant, is what's going to happen, how are we going to manage the anger, all that sort of piece of it. So this is one of these really kind of, it's a difficult one, but let's take it a little bit further. This is where the medical society is housed. Is that right? Where is the licensing board housed? Is it nearby? So a couple blocks this way. So at the end of the day, what is this kind of activity? Yeah.
To me, this is a violation to the patient, just as if they had been under an anesthesia and something was done to them, unbeknownst to them.
I am so glad to hear you say that.
A violation.
That's right.
Period.
Right. So this is a huge violation of their body.
Correct.
By this. And that's why I actually brought the issue up about the initials. There's a huge case that was in England where a surgeon was carving the initials, in internal organs of the patient and ultimately, got busted for it. Because not just a violation, but what is this? Where's my lawyer? What is this legally? That a lot of people would say legally and agreed legally. Yeah, or some would say battery, which battery is the unconsented to touching, independent of what you think about what it is. And so a lot of people, this is a crime. This is a crime. So one of the things I recommended is they needed to get a hold of the local gendarmes and make sure we knew this, and they did not decide to pursue it as a crime. But what else is it, kind of getting back to what you said, and how do we manage that? Because you're there, this is a violation of their bodily integrity. And I like the fact you bring up anesthesia, because as an anesthesiologist, it tortures me to read about the molestation and the other things that happen when you're totally asleep. Well, no, you are, and that's right.
When you were asleep, to me, this is the same.
And that's a crime, right? That's a crime, battery, assault, whatever your state definition of the crime is. But what else is it from our approach in nursing and medicine and the licensed professions, where remember we are blessed with being able to do some of the most amazing things with our patients. We're allowed to do things to help them that otherwise would be crimes. It's the patient's right and dignity to know, but what is it for the resident who did this? How would you manage, what would you do with that resident who did this?
He should be turned in.
Turned into whom?
To the medical board.
So right, so at the end of the day, I'm pretty sure Iowa would haven't looked at it lately. This is a professional ethics action that should be reported to the licensing board.
Correct.
Okay, so we all agreed to that in this case. So then what? Now what am I worried about? The state licensing board is going to reach out to the patient and say, so what do you know about these holes that have been drilled in your skull? So I'm advising the organization to say, if you're going to go down that pathway, you need to think about all these other things. And so God, this got complicated. So in this state, I happen to know the chair of the licensing board who would review this. So I called the chair and I gave him the typical legal hypothetical. Hypothetically, would you ever have a case where this situation would agree with what you said, which is the harm is going to happen if you tell the patient? Would there ever be a circumstance you'd take that in consideration and not call the patient? Or is it absolutely something you would do? Because then that helps inform what the ultimate decision is.
I think if your gut's telling you it, you're probably better off to tell them. I said, I think if your gut is giving you that, then there's probably something to question and you should report it and let them make the decision.
And not tell the patient?
No. Oh, I misunderstood your question.
No, well,
Yeah.
so you got to report it. But what I needed to know information-wise to bring back to the organization is, by the way, you may really have to tell them because they are going to reach out to them, and that's not an option. I was just trying to gather.
Yeah.
It's like Tom said, you want all the information you can doing that. The question is, in light of everything that you've heard, would you get Glenn, who's the guy talking to the neonatal parents, would you get somebody like that to have a conversation and explain to the patient what had happened, or would you just kind of sit on it?
It seems like the right thing to do.
Right. And by doing the right thing, you're setting an example in the organization. It's a new day, and we're going to normalize compassion and honesty. We'll do it in a very honest way.
And you want to make sure you have the picture of then and then
Yep, and it's not an issue now. We just want to let you know it was there and all that piece.
Not anymore.
Yep. What other information, when this comes to your knowledge, what other really important bits of information you'd like to know? Well, the reason he did it is because he'd been bullied by his senior resident. He's sitting in the back and he's doing it, and he had no idea it was going to create an X-ray that looked like that. But he knew he was drilling the holes like that. What else would you want to know?
What did you do with the guy who was doing the bullying?
Well, unfortunately, he graduated from the program, so over which you no longer have corrective action authority. And it's kind of hard to recreate the bullying and all that piece. But the program director lost his job. Because that was considered to be reckless to just say, hey, don't do it again. So there was corrective action at different levels of the organization. What else would you want to know?
Did he do it on any other patients?
Hello. God, you're really smart. I'm glad you're sitting towards the front. So they looked at a crap load of x-rays because of that question. No, only one. So should we move on, or do you want to know what happened? Okay. Well, there's kind of the good news, and then there is the horrible, tragic news, which is they told the patient, handled it really well, kind of laughed it off, showed both x-rays. God, what an idiot. And as Bruce and I know, after we presented this, a few months after that, we learned that the resident took his life and committed suicide after he was called on it. Committed suicide. So it is one of these cases which you agonize about, and how really important this conversation is today that we will have, and if you come to the other workshops to do that part. But it leads into the other piece that we want to talk to you about, which is this issue around just culture. And because this was not just in terms of all the stuff that happened related to that, this particular event. How many of you have training in your organizations or training yourself in just culture? So for those of you who've done it, how do you define it? Like, what's your quick elevator speech of what is just culture? How would you describe it?
We describe it as a consistent roadmap or a consistent algorithm that helps us. We describe it in our organization as a consistent algorithm or a consistent roadmap that helps us determine the intent behind an issue and then how best to approach from a resolution standpoint.
From a resolution standpoint.
Right.
Okay.
Or action, what are we going to do? Are we going to console the nurse who made that medication error? Or are we going to terminate her for making a medication
so
error?
it's when we're looking at the human behaviors.
Right.
How do we evaluate, assess them in a fairly standardized way to decide what are we going to do potentially from a corrective action standpoint?
Correct.
Yeah. What it is it's early, sort of early on, there was this whole move to a blame-free culture. And people began to believe, well, blame-free is a zero accountability culture. Because when you say blame-free, you can behave any way you want to, and you'll never suffer corrective action. That's blame-free. Versus, more typically what we see is the shame and the blame, piece that's out there, which we know, and you'll see a quote in a minute, is one of the reasons why we haven't gotten safer. Punishing people for being human and making mistakes will never get you to high reliability. You cannot punish yourself to perfection. And so it is really important to begin to look at the behaviors, that the people are engaged in as you do this. And so the just culture, some people call it fair and accountable. It's fair, but we are going to hold you accountable, and so it's a really important piece to think about. I love these two quotes. Lucian Leaps is the first one. It's kind of what I referred to, which is, the single greatest impediment to error prevention in the medical industry is we punish people for making mistakes or being human, because that's the book, To Err is Human. And I like James' reason, because when we do the event review workshop, we're going to talk about the fact that we cannot change the human condition, but we can change the conditions under which humans work. That is using human factors process redesign, and we're going to talk a lot about that in workshop 2. We're going to give you events, we're going to have medical records, and we're going to talk about how might you want to redesign this so it really doesn't happen again. And it's not the typical process improvement, right? Which is, we'll do an in-service, we'll put a sign up, and we'll repolicy something. Which never really changes things. It's like Einstein says, you're kind of basically doing the same thing over and over again, which is and expecting a different result, which is definition of insanity. So anyway, the whole notion around here is about, how do we change the way we do? Because preventing human error, until we get all robots doing it all the time that are perfect, we're always going to have the errors that happen. So here's an example of a real kind of human factors story where in my own personal life, I wished I'd been treated with just culture. So as many people know, I always try to take my family on a ski trip between Christmas and New Year's. And often we go out to Colorado, we've been to Utah, all over. But this one year, I was on call for pediatric anesthesia on New Year's Day. So I needed to get there quickly. So we decided to ski in Upper Wisconsin, about 4 hours away from where I live on the west side of Chicago. I don't know if many of you noticed, I'm Irish. You know what the Irish do on New Year's Eve? But I needed to be up at 4 o'clock in the morning and be driving all the way to Chicago because I needed to be there by 7:30. So when I got up at 4 o'clock in the morning, I probably wasn't at my best. But I drive out towards the highway, I stop, I get a huge, wonderful coffee. It's like that, you know how when you make coffee and it's like perfect, like you can drink it right away, it's the perfect temperature, it tastes amazing. I get back in my car after filling up with gas and I am about as happy as can be. And I'm driving down the highway and I hear this really weird noise. I think, oh God, I've got a flat tire. But I'm driving really straight and it is 4 in the morning and I may have a little off in my perception, but my car's driving perfectly straight. So I'm thinking, it's not a flat tire. So then I look out my right rearview mirror and I see what I think is a 12-foot boa constrictor. Because what I did was I drove away with the nozzle in my gas tank. And that damn thing is flopping behind my car. So then I'm like, are you kidding me? I'm like on Highway I-35, right? And it's 4 in the morning and it's New Year's Day and there's probably 12,000 policemen ready to pull behind me to say, oh my God, what is going on here? So I get off at the next exit, I drive to the gas station, I pull that thing out, I throw it on the ground and I don't tell anybody. I don't tell a soul. I am so freaked out. It's like in healthcare, you make a mistake, you don't want to tell anybody. Except I told somebody 2 years later. And who did I tell 2 years later? I never should have told. Yes, I told my wife. So now, every single year at New Year's, I get toasted to as the only person in the family to drive away with the frickin' gas nozzle that's on there. All right, so human factors. Believe it or not, if you have friends who work in gas stations, this happens at least once a month. It happens so commonly that they require you to have on the end of that thing a nozzle so that when it pops off, it shuts off all gas delivery, which was good for me because I thought I was going to have a $30,000 bill for all that. No, I really did, but then I realized that doesn't happen. And there's 8 more of these in almost every gas station. They just go up, they hook it up, figured, okay, McDonald came through again today and forgot to pull the nozzle out. No, human factors redesign. You know what I mean, for doing this piece. So now, and I needed in just culture, that was a human error. What's supposed to happen for a simple human error? I was supposed to what? Console, otherwise known as a hug. And I did not get a hug even. I was completely shamed and blamed and ridiculed. It's terrible. I'm so mad still, and that was like 10 years ago. All right, so, other situations of being a human being. When have you done something that ridiculously embarrassed you that was one of these simple slips and lapses and other stuff that you guys have been involved in? Surely you must have had a situation happen you're willing to share. Left coffee on the top of your car.
I just walked into that door.
Okay, all right. That's awesome. Now, are you okay with this? Okay, I'm going to give you a hug. I'm going to console you for doing that. Other simple lapses or mistakes people have made.
Hey, Tim, I got one. Hey, Tim.
Yeah. Bruce.
So I was at breakfast the other day, and I normally have some tea with my breakfast, and on this day I had some French toast, which I don't normally have. So I was going to put some syrup on the French toast. I reached for the little hot water tea kettle, poured the tea right on my It was just like a look-alike thing.
Yeah.
That's all, at that hour in the morning,
Yep.
that's all I could process. It has a handle, it must be
Yep.
the syrup.
Yep,
the tea.
absolutely. Slips on others who've had those things happen. Yeah, what did you have?
So I'm the car crusher. And
Oh, true.
Yes.
Yeah, okay.
I have kids, lots of kids. So I drive a Suburban, and I pulled into my in-laws' driveway around my brother-in-law's BMW, and in front of it, I owed him $60, walked back to his BMW, put the check in his car, got back in my Suburban, put it in reverse, and crushed the BMW. And of course, I called him and I was like, I owe you more than $60.
Yeah.
I'm like, sorry. And my husband's like, you did what?
Yep.
But we're used to it now.
Well, and you need to get some console her, Jennifer. There you go.
My team is very good at consoling me.
Awesome. Other things you guys have seen that, crazy stuff that's happened. The one that got really redesigned, and I noticed this yesterday, I took a little bit of cash out of the ATM machine. They've totally redesigned that because so many people walked away leaving their cards behind. So now you got to take the card before you get. That is a process. That's a human factors process redesign. The way that they do that piece. Okay. The other part that's fun to be, if you've ever been in a store that has it, you see the handle on the door over here. That says pull. There are so many places that have that handle and it's actually push. And everybody walks up and they do it and then they run into the door like you do as well.
Should be for push.
So this happens a lot in healthcare particularly. And we need to be mindful of that when mistakes are made, whether it's the insulin piece or the others. The goal when we do the event review is to learn how to get into the tunnel of where the person was at the time in a way that we understand from them why it made sense to them to do what they did at that time. Because until you get there, you can't do process redesign. Because if it made sense to them, it's going to make sense to you possibly at some time. So that's the power of this just culture and getting people's perspective on it. So then here's this case. And this comes to me from Terry Fairbanks at MedStar. He runs the National Center for Human Factors. So people recognize what this is. Yeah, it's a defibrillator, right? So a nurse is using this. Patient goes down, needs to get shocked. Turns it on, hits the energy, charges it, goes to shock the patient, and the darn thing shuts off. Just shuts down completely. Powers it up. 3 minutes later, it's powered up. She's able to shock the patient. But she's concerned because there was this delay. Time is life. Time is brain. Time is all that. So she puts an event report in. She secures this equipment. They pull it aside. They look at it, and it's working perfectly. Absolutely perfectly. So they're a little bit confused. So they do what they always do is they then put it in simulation with different nurses, including the nurse who did the report. And here's what they published, which is staggering. 20% of the time in a code, so 1 out of 5 times in a code, what people will do is hit the green, select the energy, charge it, and because we are trained that green is good and red is bad, people will hit the green instead of the red to shock the patient when they're anxious in a code simulated being looked at. And what happens if you hit the on button after you hit the charge button? You turn it off.
Yeah, so you're
There's no warning. There's nothing that pops up and says, are you really sure? You turned us on, you picked the energy, you've charged it up, you really sure you want to turn this off? It doesn't work that way. So imagine the nurse, to her horror, who finds out and realizes, oh my God, that's probably what I did. But also the courageous part of reporting it and being into that. So again, made a mistake, clearly made a mistake, and a lot of organizations would get punished. Oh my gosh, you violated the policy. The policy says you will hit this, this, and this, and you will then shock the patient, and you clearly violated the policy. And so there's this whole different approach using the Just Culture algorithm in terms of doing that. Marty Hatley carries this in his wallet all the time. Once I showed him how this thing works. So this is a very simple algorithm that you can use in Just Culture. So look at the nurse involved in the defibrillator. Or let's go back to the resident who drilled the holes. Were the actions as intended? Yes. Were the consequences as intended? Yes. That really need to be an intervention very early on with explanation and understanding why, and really embracing this resident early on before it got out of hand, and did that. So let's take the nurse with the defibrillator. Clearly did not intend to shut it off. Great nurse. Did she knowingly violate safe procedure? No. Substitution test. Could it have happened to somebody else? Absolutely. Did it ever happen to her before? No. Blameless error. That's console. She needs a hug. Now, how about me? Little wrinkle here on the evidence of illness or substance use. I have been up all night. You know, I probably wasn't intoxicated, but I clearly had been influenced the night before. So maybe that's in there, and you know, Bruce will help manage me, you know, for that. But I didn't knowingly violate safe procedure. It does happen a lot. It was my first time. I needed a hug. I didn't need to be ridiculed by my family. No, so this is the value of using this all the time when we begin to do this, because it gets to this concept of caring for the caregiver. The fact that there are so many people who are involved in these events who feel terrible about what it is that happened, and we need to support them through this. Independent of where they flow, they needed support. That resident still needed support, which is probably one of the reasons why, unfortunately, his life ended the way that he did. And so I want to go ahead. I want you to watch this video. The other thing about this video I'd like to share is, you know that the story's going to turn out kind of really cool when you hear the banjo music. It's kind of like when you hear a movie, when the music kind of changes, you'll kind of know this part. So why don't we run? And this is a really good example of caring for the caregiver, just culture, and other pieces related to it.
Patient care technician came to me and she told me, I need to let you see this screen. And she showed me the glucometer.
She saw the word high flash on the screen, and that's what she assumed was the result that she had.
She's like, I just feel like my blood sugar is really high. She's like, I don't feel good. I know my body.
And so there wasn't really any suspicion that it would be low. And so when this error message comes up, it kind of confirmed that.
So we rechecked her blood sugar, and the same thing popped up. So I covered her with some insulin, and I called the physician. And by the time I got her back in bed, she became like non-responsive.
Ended up being a rapid response and requiring a transfer of the patient to the intensive care unit.
Nurse had misread the glucometer and called the physician, asked for insulin on multiple occasions, and the patient had a severe hypoglycemic event and had to go to the ICU before it was caught.
During the rapid response, we checked the glucose twice, I believe, and the same thing kept popping up, the screen that said glucose greater than 600. The next day is when I received the call that the whole time her blood sugar was actually critically low.
Shortly after this particular incident, another nurse made the same error where the machine it was an actual low value, but the machine read off this alert saying for a high, do X, Y, and Z.
It never came to mind that the glucometer was incorrect. It was probably the worst experience I've ever had in my professional career.
The nurse manager called our human resources department, explained the error, this is what happened. We didn't fully understand the ramifications of this piece of equipment and the message that it displayed. And they said, well, I think you need to suspend her until an investigation is completed.
I felt like I was talked to like a 5-year-old. I wasn't talked to like an adult. I mean, I'm a nurse because I come to take care of people, I come to do my job. I'm very passionate about what I do. And for a long time, it really shook me. Like when I came to work, I was scared to like take care of patients, and I was really apprehensive about everything I was doing. I wasn't really confident anymore. It really shook me to the core.
I questioned it with my boss, and she had the suggestion to invite some of the staff from the Human Factors Engineering Department in MI2 to come over and help us at least evaluate the process.
I got a call from the chief nursing officer at one of our hospitals saying that they had had a case. There was a design issue that might have contributed to the case, and they wanted us to take a closer look at it from a human factors engineering, safety engineering standpoint.
There's the banjo music.
It quickly became apparent that there was more to the story than just that she had made a mistake, and that there was a lot more, that it wasn't just her. It was the actions of lots of people that led to this hazard, and it certainly could happen again.
You can't fault any one individual. That's a process problem that needed to be addressed, and the more we thought about it, the more we decided that We needed to fix the process.
The concept of high reliability, the concept of systems problems versus people problems, the concepts involved in human factors engineering. They become very familiar to us, those of us who are talking about them all the time. They're not as familiar to the people on the front lines. Our job is to be able to share that in an effective way, one in which they can actually use the tools and change outcomes.
The leadership, when they saw our analysis of the case, they supported the fact that Annie should not have been disciplined, and they reversed the discipline. And that was doing the right thing. And I think that sent a very important message to the staff at this hospital that the leadership supports them and takes the systems approach to managing error.
There was a team there and they were all like nodding and they were all like validating. They were like, okay, so, you know, you're not incompetent. Everything you're saying makes complete sense. And it was just like, it's like I could take a breath and be like, okay, I'm not crazy. And then when I was told by my manager, she pulled me in her office after it and she was like, we're gonna take away the discipline. She was like, they actually said that we didn't treat you so fairly. And that made me feel better, and that was like a positive aspect of the experience.
We need everybody in our system, actually everybody in the healthcare industry nationally, to understand the systems approach and understand just culture, so that when we have near misses and when we have small little noticed hazards and unsafe conditions that we encounter day to day in our job, that we report it and that we look for trends, and where we can, we fix the system so that the next time that same error or near miss happens, we won't injure a patient.
Yeah. So again, all these videos are available, Kate, as you know. So just to let you know, they weren't in your handouts, but you will definitely have access to a lot of this stuff, and we got more and more and more that we'll share even with the other workshops. So this whole notion of restoring joy and meaning, it's a really critical piece as it relates to the caring for the caregiver and creating resilience and engagement, which is, again, a big part of Candor. The whole goal of Candor, remember, is create a learning environment, a loving learning environment, as Tom talked about earlier. How do we do that? These comments come actually from Paul O'Neill. Paul O'Neill, former CEO of Alcoa. Did you know him at MPSF? Because he's part of Lucian Leap Foundation now and part of MPSF. When they wrote their white paper on restoring joy and meaning in the workplace, what they said is, if your people who report to you or you work with or part of your teams can say all these things in the affirmative, you will have engagement scores off the charts and you will have ridiculously low turnover. And these are the three questions. So when we do a gap analysis in an organization, when we're really looking at rolling out, a Candor process, we do ask everybody at every level this, which is first, am I treated with dignity and respect by everybody I encounter in work? Everybody, independent of where they are in the hierarchy. Number two is, do I have what I need so I can make a contribution to my work and bring meaning to my life? And a lot of people will say even these kind of trainings are huge because they bring meaning to my life and what I do, and they are going to give me some skills that I can take further to do that. And finally, does every day, somebody I care about and respect notice what I did? So again, a big part of building resilience and joy and meaning in the workplace. The other part is things that you can do that support caring for the caregiver. The first is, as we talked about, establishing respect and civility through just culture. The approach you just heard, whether it's Annie, whether it's the nurse with the defibrillator, doing that. And then creating a learning and improving culture, and this wonderful article about, burnout and redesigning care. Tom, I don't know if you saw it, but it was published. David Bates was one of them. Bruce, you shared that with me. I was with the lead article on that paper that you shared with me about the EMR. They did a study measuring how much docs and nurses documented in EMR versus those in other countries that don't have our billing, regulatory, and other requirements. And what they found is, in the US, we do 400 to 600 times more documentation in the EMR. 400 to 600 times more. And so they had this beautiful curve. Bruce, do you remember looking at that? Do you want to comment on that a little bit? Because that was So I even talked about that yesterday at University of California, San Diego.
I can't
the lead
remember-
author has gotten hugely interested.
I can't remember exactly what the curve looked like, but it basically showed that there was a correlation between what the number of clicks you made and burnout, or
Yes.
what was the other? That was the
Yeah.
main.
Yep.
And the number of clicks, of course, is a frighteningly large number of clicks. Though the one thing I do have to say about that is, how many clicks does the non-doctor make in their life? I mean, let's face it, we spend a lot of time clicking, but still, there was a huge number of clicks. It was more in the United States than it is elsewhere.
Way more.
And it was
Yep.
correlated to burnout and negatively correlated with the amount of time you spend with patients and so on.
Yeah. So the reason I say that is part of this, the process, when we learn about harm events and how people are doing, one of the human factors commitments is how can we make work more efficient? How can we, if we're going to change things, make it less work we have to do instead of more work we have to do? Why build 12 other different things in to prevent the medication error instead of getting rid of all of them, except maybe one or two? So, and that's talked about in the New England Journal article. And the other is this piece we're going to move into now, which is caring for others when things go wrong. And that's a critical piece. Many of you may have heard the second victim phrase. We don't like to use it a lot because of our patient advocates. You know, they're feeling appropriately, strongly that there's only one victim. But the second victim, it is a name out there. It is used. The definition I put up there was Albert Wu in 2000 defined it. Have any of you heard of the third victim? And who the third victim is? Because that's out there now. And it's everybody in the room right now. It is those that have to deal with the harm events all the time. You're getting pummeled. Nobody ever calls you to say, oh God, things were perfect today. We did a perfect timeout. We had no surgical site infection. There was no CLABSI. There was no CAUTI. The patient left and they're really happy. Nobody puts an event report in like that. It's all, and so part of resilience is bouncing back from getting pummeled all day long. So there's a lot of people who need care. When we put the Candor process together, we had to create a whole separate approach to all of our safety and risk managers who are now having all these conversations. And it was amazing what we had to do to support them, because now they're leaning in and they're having more tough conversations doing that. Any of you have had an experience of somebody you know who had a horrible event that happened in healthcare, and they might have benefited from some peer support or emotional first aid or what have you? Anybody you know, or situations you saw others related to that you can remember or you can share? I see a lot of interesting looks on people's faces. In almost everybody, they reflect back and they can think of him. When Bruce and I did this in Northern California, one of the people who raised their hand was the surgeon at Columbine, who was taking care of her colleagues' kids who'd been shot and killed in the ED. And she never got support. So she talked a lot about, wow, it would be really good to have that kind of piece, that kind of thing in place. So a lot of people, when they reflect, they have their own personal stories, or they know others who are that way. And so the reason it's so important is, like the insulin overdose, like the doc who may miss this x-ray, it can create huge feelings of personal responsibility, the sense of having failed, and they begin to second guess their clinical knowledge. And there are many, many symptoms that lead into this whole notion of burnout. And we know burnout is going up logarithmically. I mean, and again, a lot of it goes back to the MR, but there's a lot of other pieces that are related to that. So these can cause huge changes in how they're behaving. But here's the other piece is, for people who are really burned out or really suffering from this, they will commit more mistakes, and it creates kind of this vicious cycle. There's also been a recent study published looking at burnout, showing if you look in your ICUs, the units with the highest nursing and physician burnout have the highest mortality rates observed over expected. They will also have your worst CAUTI rates based on burnout. It's really beginning, and that's why this whole notion of providing a care for the caregiver peer support process is so important. So what a second, where's Bruce? No way. Really? I'm going to have to do his part? But anyway, so this is what second victims want. These are there's Bruce. These are the pieces that one of the biggest parts is remaining a trusted member of the team, in terms of doing that. These are the different strategies that organizations put together. The second layer is what we're doing today. We're giving you some ideas around how to provide empathic first aid to doctors and nurses when things happen. That's often tier 2. Tier 1 is just how do we support each other on the unit. Tier 3 is typical EAP. What is one of the problems or difficulties with EAP? I mean, love it. They do great work. But what's one of the challenges in what we're trying to achieve here with EAP? Getting people to use it, right? I mean, for me as a doc, to go to EAP is a sign of weakness, and then I worry, are they keeping a file on me? Somebody going to find out about this? So tier 2 you're going to hear about is sort of this proactive way to provide emotional first aid that doesn't get written down anywhere. It's a way to really begin to support and do that. And tier 1 is just your local support. Bruce, you want to take it from here? I know you love Pam, and we've got a lot of those things you recommend sharing with people that you can do before we take our break and go into enactments. But I have the numbers there. As you can see, this was the number in November 2017, and then it's just kept going up, and here's your clicker.
So about 6 or 9 months ago, I became aware of this woman, Pam Weibel. I saw something she'd written on Twitter. I think she's now given a TED Talk also. But she wrote this article. I think it first appeared on Medium, just a self-published thing, what I've learned from 949 doctor suicides. And so Pam writes about physician suicide. And there is, I think, what you could safely call an epidemic of physician suicide. And you could Google this and read the article or watch her talk. It's really an interesting and very sad thing to say. And if you're on Twitter, and I'm not recommending you go on Twitter, it just drives you crazy being on Twitter, but if you're on Twitter, you could follow Pam, and you'll hear about basically each new physician suicide that comes to her attention. And she makes a really significant effort to try to tell the story of the individual physician that had died and what the circumstances were. She's a very passionate advocate. I don't agree with everything that she says. She believes a lot of what's going on in hospitals. She refers to them as human rights violations. It's not just poor working conditions and so on. But what this sensitized me and Tim to, Tim and I have both known physicians and other healthcare professionals who have died by suicide, and we're moved by it, and we're saddened by it, and we know that from all the stories we've heard how traumatized you all are. Occasionally we ask for stories about trauma, and they're really intense when we hear them, and we never know whether there's someone in this room today that could be thinking about suicide and that might need help. So we offer this number as just a lifeline. It might be you, it might be someone that you work closely with, and we hope that you'll ask for help. You're not alone. There's help to be had. It's a very, very difficult job that you have. And one of our goals in doing the care for the caregiver type of work is to try and stem the bleeding, right? The metaphor we often use is emotional first aid. That's what care for the caregiver is. If you have a colleague who's suicidal, you're not a therapist. You're not going to be able to give them therapy and provide them that kind of care. But you might be able to at least remind them that they're not alone, walk them down to get the help they need, be there for them, let them have their experience in the presence of someone that they know and trust. So I want to talk about our kind of general approach to caring for your colleagues. There's going to be some overlap between the themes around empathy, which we discussed this morning, because empathy is the same whether you're offering empathy to a family or whether you're offering empathy to your colleagues. So there's some similar themes. You want to adopt this stance of solidarity, meaning we're in this together. One of the main messages you want to be able to get across is you're not alone. We're in this together. Curiosity, what I've mentioned before, and support. You're going to acknowledge and name their emotional states. This is kind of empathy 101. Name those emotions. Express regret for the bad outcome. Just tell them you're sorry that they were involved in this terrible thing. They're sorry this is happening to them and they're going through such a hard time. Let them know that any strong emotional reaction is normal. This is part of, remember what we talked about before, allowing them to feel however they're feeling and letting them know that their feelings of despair or shock or sadness or regret or fear or whatever it is are okay feelings to have. Again, we want to invite them to elaborate on their thoughts. People don't always know what they're feeling. So empathy consists in part in inviting people to talk about their feelings so that they can name their own feelings. Right? I talk about empathy being name their feelings. You seem angry, you seem upset, you seem scared, you seem grief-stricken. But people don't know exactly what they're feeling. It's an illusion. We think that because feelings are visceral and because we feel them so intensely that we understand them clearly. But there's a difference between feeling something intensely and understanding it clearly. I think that there's many days where I wake up on the wrong side of the bed and I just feel bad. And it takes me till the middle of the day, or sometimes till the next day, or sometimes till the next week to try to figure out what was I feeling. People who care about me might ask me, say, you're grumpy, or well, what's bothering you? And the answer is, I don't know. I don't know. And it takes until I can talk with a friend to try to figure out what might be bothering me. So we can give this gift to our friends and let them talk about it so that they might be able to figure out what's bothering them. The simple techniques, paraphrasing, just virtually repeating back to people what they said to you in slightly different words so that you can check your understanding. So people tell you they're really angry and upset about something, and you just say back to them, so you're still really angry about the way that this guy treated you in that meeting. Okay, just simply paraphrase so you can check understanding. And then like Abe Lincoln does, acknowledging the limits of language and empathy, recognizing that often there's not much we can say. I wish I could remember what he said, right? There's no words that can quell your grief of such a serious loss. That's sometimes how it is for our colleagues. If a colleague has been present or made a significant error that harmed or killed a patient, nothing you can say is going to completely lift that burden. They're going to live with that burden the rest of their lives. So what can you do? You can be with them as they suffer so they know that they're not alone. You can recognize where they're at. You can acknowledge the depth of their pain. Those things will help. There's nothing we can do to cheer them up. People are not children. We can't distract them with a candy bar or ice cream and cheer them up. People are deep in their grief or sadness, and that's where they're going to be no matter what you say. So what can we actually say? So you may not realize it, but the communication studies is a science for what it's worth, social science, and there's actually a lot of evidence about what works to support people emotionally and what doesn't. So I've drawn these specific tips from an article by my late colleague Brant Burleson, who was a professor at Purdue for many years, and he wrote a review article called Emotional Support Skill. And I've extracted from that the main advice about what to say and what not to say. So what to say? Express a desire for help. These are evidence-based best practices in comforting people. I really want to help you get through this. Express positive regard for the other person. You're such a good and kind person. This is comforting to hear when we're feeling terrible about ourselves. I care about you so much, so express care, concern, and interest in the other person. Let them know you're there for them. People are afraid of being abandoned and are very comforted by knowing that you're available. Now, how often has a close friend told you, you can call me anytime? And we know 80% of those people are lying, right? 80% of those people, we call them in the middle of the night and go, what the hell are you calling me for? Do you realize what time it is? But we also know, there's this test, Tim talks about this test, right?
4 a.m. test.
Yeah,
Are you aware of the 4 a.m. test?
So think about in your life, is there someone you can call at 4 a.m. if you are in desperate need? And it turns out that if the answer to that question is no, you're at significantly higher risk for morbidity than people who answer that. Mortality, I'm sorry. Than people who answer that question with a yes.
Yep.
So this has to do with loneliness and social isolation and so on. So another gift we can give to our colleagues who are hurting is to let them know that we're available and to mean it. Right, to give them our number and let them know they can call us and that we're available to them. This is the solidarity thing. You don't have to go through it alone. So often, there's nothing we can actually do, right? The world is a big, complicated place that we have no control over. As health professionals, you know that better than most. People wake up in the morning and they don't make it through the day. They end up dead before the end of the day. And they didn't expect to be dead when they woke up that morning. So the world is a great, big, out-of-control place. And so many times, there's nothing we can do about it. Events have a power and a logic of their own. All we can do is be there with our friends as they endure what they have to endure. And somehow, by the nature of being human, that helps us a lot. Simply being there for people actually helps us a lot. There's so many times in my life where I've had big problems in relationships or work or family or whatever, and I'm depressed, I'm sad, I'm anxious, but I managed to drag myself out of the house against my own judgment and spend time with friends. And then after hours spending time with friends, I feel better. I don't know why. None of the circumstances have changed, right? The underlying circumstances that made me anxious or sad are unchanged, but 3 or 4 hours with my friends and I feel better. And I'm not talking about alcohol. I'm talking about simply the company of my friends made me feel better. So we can offer that to people. It costs us nothing. Express acknowledgement and comprehension, this sorrow and condolence. So we can just say, I'm so sorry. I know how much this meant to you. Legitimize their feelings. There's some repetition here, but I think these ideas are important enough they bear repetition. You have all this in writing, so I'll move through some of this quickly. Of course you're frightened. Anyone would be. This is a really scary situation. This is a way of validating how they're feeling. Acknowledge their plight. It totally sucks to work so hard and so long towards a goal and then not achieve it. Or in the circumstances of care for the caregiver, something like, to try to help a patient and then to end up hurting them is just the worst feeling in the world. Absolve them of blame or guilt. So, we may or may not be able to do this all the time in a care for the caregiver situation. Sometimes there really is no guilt. You get put into a situation, a terrible thing happens to a patient, you happen to be the one at the sharp end, standing over the bed when everything falls apart. But if you were to unpack it all, there were 50 different things that went wrong. Anyone in your place would have made the same mistake, but you were the one that it happened to. In those circumstances, there really is no blame. We're going to do a case later today where there's really no blame. A nurse does a terrible thing, but through no fault of her own. So we can absolve people of the guilt because they're often overwhelmed by guilt and shame. Let them know that any feelings are okay, that no feelings are off limits for the reasons I described this morning. And encourage elaboration. So this is all the stuff I've talked about, this catharsis idea that if they're encouraged to elaborate their feelings, they will gain command of our feelings. And the feelings we think of as being purely emotional or affective, but they're actually partly cognitive. In fact, their origins are completely cognitive. The modern theory of emotions is that they are the result of a cognitive appraisal of the situation. So we appraise a situation. What's that light in the distance? Oh, it's a train. That train is coming right towards me. Do I have time to get off the tracks? I'm very, very afraid, right? It's all the result of a cognitive appraisal. If I realize, oh, it's on the other track, or it's not a train, it's a spotlight or something like that, then I'm not afraid at all. So emotion is the end result of a story we tell ourselves about external circumstances and how they're impinging on us. So being able to express and elaborate our own feelings often helps us come to a reappraisal of our own feelings, which allows us to feel differently. Ask open-ended questions. How have those feelings of fear or sadness or despair been lately? Reflect and restate. From what I can tell, you're still really sad about the end of that relationship. You're not sure you're ever going to get over it. This is helping people, reflecting. This is part of paraphrasing, letting them know you understand and you're listening. Offer hypotheses because people don't know why they're feeling what they're feeling. Could it be you feel guilty? You didn't do more to help your friend when she was sick? Use back channel cues. This is the nonverbal. Yeah. I tell a story sometimes that I had a friend who it was after my divorce more than 10 years ago, and I was calling his wife, actually. His wife is a social worker, and I knew she was good at empathy. I needed some empathy, so I called the social worker for some. Any social workers in the room today? No. So I needed some empathy from my friend, the social worker. So I called her, and I got my friend, the husband, on the phone. He's an old friend. I know that he loves me, and he said he was waiting for his wife to come to the phone, and he was feeling awkward. There was this awkward silence with my sadness and him not knowing what to do about it. And so he finally asked me, "How you doing, Bruce?" And I think he didn't really want to know. He asked me, and I said, and I started to dump I'm feeling terrible, I'm so sad, etc. And he just went, That was his response to me. I love him so much. He's still my dear friend. But he had no idea what to say. But it's still, he heard me. I knew he heard me. I knew he was really not capable of giving me the empathy that I wanted, but that was okay. But often, this is more like...
But you could call him at 4 a.m, Bruce.
He would
and
answer
he would pick up.
He
would be one to pick
that's
up.
That's right.
Yep.
He's the sort of typical man. He took me to a Cubs game. That was his way of comforting me. But this is just to let people know you're listening. Sometimes we want to be quiet for a long time. If you've had friends who are really in distress, they can talk a long time. People in distress want to tell their story over and over and over and over and over again because they're trying to get command of it in their own heart and their own head. So just let them, so that they know that you're listening. Things not to do. These are evidence-based things not to do, okay? Don't say you know how they feel. It's presumptuous. Don't dwell on your own emotions. As Tom Gallagher, our friend, often tells the story of a surgeon who had committed a bad error, went in to tell the family, and he started off by saying to them, "For you, this is bad, but for me, it's shattering." Yeah. It's not about you. When you're comforting someone else, it's not about you. So comforting other people requires humility. You have to factor yourself out, even if you've been in a very similar situation. It might eventually be relevant for you to reflect on your own experience. They might ask you, has anything like this ever happened to you? And then it might be relevant to talk a little bit about your experience. But even then, it's not about you. You can't make it about you. That's a sort of narcissistic response. And the comforting is about the other person and making yourself available to the other person. Don't attempt to investigate. A whole other group was going to do this. When you're doing care for the caregiver, it's emotional first aid. There's a whole other team investigating the event.
Workshop too.
And that's not your job. And it confuses the issues. It clouds the issues. Once that you start to investigate, they may not feel comfortable talking to you. You may get yourself into legal trouble. You're not investigating. Don't make promises you can't keep. Everything's going to be fine. You're not going to lose your license. You're not going to get fired. It's going to be fine. They won't sue you, I promise. You can't make all those promises. You don't know the answer to any of those questions. So don't make promises you can't keep. Don't finger point or blame or criticize or judge anybody. It's not going to help them. It won't comfort them. Don't do all the talking. Remember I said this morning, when you're providing empathy, if you're doing most of the talking, you're kind of doing it wrong. You're going to do a little bit of talking, but mostly you're going to be listening. Empathy is mostly about being present and listening, affirming and being present for them and being vulnerable and not doing all the talking. Don't try to minimize the severity of what happened to them or the intensity of their feelings. Sometimes we think that people are feeling such intense feelings, sadness or grief or pain or anxiety, and we can see that they're suffering. And because we love them or care about them, we want that suffering to be less intense. We want the feelings to be less intense because we can see how burdened they are. So we want to minimize the intensity of the feelings. But that isn't what really helps people. What seems to help people is being present with them in the intensity of their feelings. Their feelings have a life of their own, a life history, a natural history and life course, a trajectory of their own. The intensity, we've all had intense feelings of grief or anger or despair or whatever, and they don't last forever. They sometimes last much longer than we want, but they don't last forever. And so we can be there with their intense feelings and not try to minimize them. And don't try to make them feel any other way other than how they're feeling. So this is, when we have little children and they bump their knee and they scrape their knee and they start to cry, we want to do something and cheer them up. And we want to cheer them up and change the way they're feeling. But that's the way you comfort a child. And even with children, it's not completely effective. But adults are not children. We don't want to try to change the way they're feeling. We want to be with them where they are, say yes to their experience. That means accept how they're feeling, completely accept it, even if in our heart of hearts, we believe they're reacting the wrong way, right? How many times have you had a friend or family member you think, they're having the wrong feelings. I don't accept their feelings. I think those are the wrong feelings to have, I think those feelings are too intense or misguided. I think their interpretations are wrong. None of that may all be true. None of saying any of that isn't going to help. So if the goal is to comfort your friend, you just can't say any of that. You have to accept where they're at. You think, well, I'm validating their crazy thoughts or beliefs. So be it. You're going to be in there trying to be there with them. You don't have to necessarily endorse that what they're saying is true, but you can endorse that they're feeling that way, right? That they're despairing, that they think they're going to lose their job and their life is over. You don't have to say, agree with them. Yeah, your life is over. I can see that, But you can say, I can hear you are afraid that it's all over, that your career is over. So you acknowledge what they're feeling without necessarily acknowledging the reality of their interpretation or agreeing with their interpretations. So it says we're on for a break. Is that where we're at?
Yep. So let's go to 2:30, and then we'll do our last two enactments, and then we'll do a debrief and lessons learned. So let's regroup in about 12 to 14 minutes.
Perfect.